Hello, and thank you all for attending our PRN webinar session titled COVID-19 Vaccination Implications for the Ambulatory Care Pharmacist. Today we have three awesome speakers who will each provide us with some updates in three areas that we felt would be great for our audience as we begin to really ramp up our vaccination efforts across the country. So first we'll have Dr. Ellen Jones. Ellen is an assistant professor of pharmacy at Harding University in Searcy, Arkansas. She received her PharmD at age 40 after working in the arts for many years. In addition to coordinating courses in patient-centered care and self-care therapeutics, she currently practices in precepts at an independent primary care clinic. Dr. Jones has been married for 25 years and has 2 teenage daughters and 2 sweet puppies. She has coordinated COVID-19 vaccine clinics on Harding's campus, where approximately 1,200 doses have been provided to date. Dr. Jones will speak to us today on the background and general information related to our current vaccines. Second, we'll have Dr. John Shilka. John is a clinical pharmacist and clinical assistant professor with the University of Illinois Hospital and Health Sciences System and the University of Illinois Chicago College of Pharmacy. He attended UIC for pharmacy school and then completed a PGY1 with Rush University Medical Center and a PGY2 in ambulatory care pharmacy with UI Health. Personally, John enjoys watching the Chicago Bears and fantasy football. Professionally, Dr. Shilka has been participating in COVID-19 vaccine clinics at UI Health for employees and the public, and will bring some of that expertise to us today with his vaccination pearls on things such as administration, contraindications, and management of ADRs. Our third and final speaker and panelist today is Dr. Ann Philbrick. Ann is an associate professor at the College of Pharmacy and the Department of Family Medicine and Community Health at the University of Minnesota. She is on the faculty of St. Joseph's Family Medicine Residency Program and maintains her pharmacy practice at Bethesda Family Medicine Clinic. She is a 2006 graduate of the University of Nebraska Medical Center and completed a combined PGY1 and PGY2 ambulatory care residency at the University of Iowa Hospitals and Clinics in 2008. Today, she will share expertise, tips, and other valuable information to assist us as we carry forth vaccinating members of our respective communities. Throughout the session, if you all have any questions, please pop those in the Q&A box, and we'll try to address them during our panel session at the end of the talk. With that being said, I'll turn it over to Dr. Jones to begin her portion. Thank you. Dr. Jones.
Good afternoon. Welcome, everybody. You can go ahead and start my slides. Yeah, so my presentation is called I'm Not Throwing Away My Shot. Being a theater major, a background, I can't resist a good Hamilton reference. So my objectives today are just going to talk about kind of the nuts and bolts about the vaccine storage, handling, things like that, and then how to prepare and administer. So my place of practice is Harding University College of Pharmacy in Arkansas. We have been providing vaccines to our employees, mainly our food service employees, our housekeeping staff, and then now students, faculty, and some family members. We've done about 1,200 so far, and mostly what we've done is the Pfizer. We have done some Moderna, but no Jansen yet. And then in addition, all of our students are required to do a certain number of hours every year of pharmacy service learning. And so they've volunteered hundreds of hours throughout the state with different independent pharmacies and other agencies. We receive our vaccine as part of a hub and spoke model that we use in Arkansas, where larger entities receive large supplies of the vaccine, and then smaller places receive parts that we need at any given time. So we've become a spoke as part of the hub and spoke model. Next slide. So first I'm going to talk about the Pfizer BioNTech vaccine. It came on the market, well, it was approved for emergency use on December 11th, 2020. It is a 2-dose series separated by 21 days or 3 weeks. It was originally designed to just be 5 doses per vial, but pharmacists soon learned that 6 doses, you could get 6 doses out of 1 vial, and so we started to do that, and that has been approved now from the FDA for that to happen. And so when you receive doses, that's how it is, how it's calculated. It is the only one that's currently approved for ages 16 and up. And they're actually in studies They're in trials they did a trial for ages 12 through 15, and they're awaiting the results for that. And they are just about to start ages 6 months through 11 years, trialing different doses of the vaccine. And the contraindications are currently just a severe allergic reaction to this vaccine or an ingredient of the vaccine. And one of the ingredients is polyethylene glycol. So if you have an allergy to that, it's contraindicated. You see down here the ingredients. It is an mRNA vaccine, which is sort of like a roadmap that we give to people, and it tells our body how to produce the antibodies. And then you can see there that polyethylene glycol is one of the ingredients, and so that is why it's a contraindication if you have that allergy. It is an IM injection, just like any other standard IM injection. It is 0.3 mils, while these are 0.5 mils. And then those are some of the reported side effects, and I think those are going to be discussed some later. But something to consider, you'll see there's swollen lymph nodes. And so if you do have a patient that has had a mastectomy, you want to avoid giving the vaccine in the arm where they've had the mastectomy. So that is something to consider. Next slide. So here's some storage information. This one has to be stored in ultra cold temperatures, so -80 to -60 Celsius. But then it can be removed from that ultra cold storage into a normal freezer temperature for up to 2 weeks. But that is cumulative. And so if it comes out for a few hours, those hours are subtracted from the 2 weeks. It does have to be kept frozen until it is ready to use. Then you can thaw it in the refrigerator, but once it is in the refrigerator, you must use it within 5 days. And then it is for immediate use. And so once it has been thawed, it should sit for about 30 minutes at room temperature to thaw. And then you dilute it. And once it's been diluted, it needs to be given within 6 hours, and it does need to be protected from light. Next slide. So to prepare it, you take the vial, and if you can see, you invert it gently 10 times, slowly. It's not to be shaken. And you dilute it with 1.8 mils of sterile saline, not bacteriostatic, using a 21 gauge or smaller needle. I think every state is different. In our state, we receive all of the supplies that go with the vaccine that we would need. So we do not have to provide our own syringes or needles. Those all come with the vaccine. So we are given 2 mil vials of normal saline, which we use 1 per vial of vaccine. Once you do put the 1.8 mils, there is no vacuum in that vial. And so you want to let go of your syringe and let that pressure equalize, because the plunger will push back out of that syringe so that you equalize that pressure. Then when you remove that needle, you invert again 10 times. We do like to use low dead volume syringes like the Vantage Point needles because that allows us to get more out of the vial. And it is a 0.3 mil dose. So each vial does have 6 doses. It has to get 7 out, but you certainly can't count on it. You are not allowed to pool the doses. So if you have half of dose in one vial and half in another, those are not to be combined. We actually use, we've gotten some Vantage Points, but there's been a shortage. And so we use some Vantage Point and some 1 mil with a 25 gauge needle. And what we'll do is we'll do 3 and 3, and that makes sure that we get 6 doses out. That's just a trick that we have learned. For administration, it's intramuscular into the deltoid. You want to avoid a SERVA, which is a shoulder injury related to vaccine administration. And that's what happens when somebody gets too high with their administration, and it gets into the bursa of that shoulder, and it can cause problems. After it has been administered, the patient needs to wait for 15 minutes somewhere where they can be observed to make sure there are no severe adverse effects such as anaphylaxis. If a patient has had an anaphylactic reaction in the past, we do like them to wait for 30 minutes so that we can keep an eye on them for longer just in case. The last information that I saw was the average, if it was going to happen, was at 22 minutes. I will say that we did have one patient that experienced anaphylaxis. They waited their 15 minutes, got in their car, and drove away, and they were away, and they called us. And the ambulance came and they gave them an EpiPen. So it did happen after 15 minutes. So that's just a piece of information. Okay, so the second vaccine to gain approval was the Moderna, and that happened the week after on December 18th, 2020. It is also a 2-dose series separated by 28 days instead of 21. So this is a 4-week. Both of them, both Moderna and Pfizer, have been extended to 42 days as a window. So if they miss that 21 or 28-day window, they have up until 42 days to still be within range. If they miss that, they do not need to repeat the first dose, but the ideal is 21 with Pfizer and 28 with Moderna. These are multi-dose vials, 10 doses per vial. It is possible to get 11, and they come in a carton of 10 vials. It just happened this week. Now they're going to produce a 15-dose vial, which actually has 13 to 15 doses in it. That makes it simpler in some ways and harder in some situations if you're trying to use up a vial. But it is approved for ages 18 and up. They did a trial of 12 to 17-year-olds in December, and they're about to start now testing it on ages 12 and under. Similar contraindications, severe allergic reactions, and then this one has polyethylene glycol as well, so if they have an allergy to that. And then those are your ingredients there, so the mRNA. It's also IM. This one is a 0.5 ml dose. Similar side effects to the Pfizer. Okay, we can go on to the next slide. Storage, this one only has to be stored in your typical freezer, -25 to -15 Celsius. It does not need to be stored below -40 like on dry ice. It also needs to be protected from light. These can stay in the refrigerator for up to 30 days prior to first use, which makes them much more convenient for your, smaller places that aren't going to be doing mass vaccinations in a day. It does not need to be refrozen. If you take the vials out of the freezer or the refrigerator at room temperature, they're good for up to 12 hours, unpunctured. And then for this one, instead of inverting 10 times, you are to swirl it. So this is a swirl one. And after you draw the first dose, it should be between 2 and 25 Celsius. And up until this week, it was supposed to be discarded after 6 hours, but just yesterday I read that they had changed the emergency use authorization, and it's actually good for 12 hours out of the fridge. So that is good news. And they may have some particulate matter in them. Also, it says in there, it's possible there may be some white or translucent particulates, and that's okay for both of these actually. So if you notice anything besides that, you need to not use it and ask the manufacturer. Okay, next is Jansen. This one is a more recent, or Jansen is actually how they pronounce it, Jansen, or Johnson & Johnson. It was approved on February 27th, 2021. It is a single dose, which makes it much more convenient. This one has 5 doses per vial. I've not worked with this one, so I don't know if it's actually possible to get 6 out of it. This one is approved for ages 18 and up. And then similar contraindications, but this one uses polysorbate as one of its ingredients. And so if someone has an allergy to that, it is contraindicated. This one actually uses an adenovirus as a vector in order to deliver that vaccine, and you can read about that. It's been stabilized, and then it has 5 times 10 to the 10th actual viral particles within each dose, and then you can see your inactive ingredients there, and You see the polysorbate, that is why it is contraindicated in that allergy. It's also IM, it's a 0.5 ml dose, and then these are the common side effects. I anecdotally have heard there's a little bit more GI side effects associated with this one than the other two, but I'm sure the other panelists are going to speak to those things. And yeah, so this one also can be stored at refrigerated temperature and protected from light, so it does not require that ultra cold storage. It's okay at room temperature for up to 12 hours. This is another swirl for 10 seconds before drawing up doses. And then it is okay to store for 6 hours at room temperature. No, I'm sorry, 6 hours at refrigerated temperature and 2 hours at room temperature, sorry. And then if you do not use it up within those times, you do need to discard it. Post-vaccination, any sort of adverse events need to be reported to the VAERS. That is a patients can report there, but also we as clinicians can report that to that agency. And then after you give the dose, obviously we need to make sure that we're reporting everything to each state's vaccine registry, and then make sure we're giving the patient their vaccine card so that they have a record of that. VSafe is a program that the FDA uses to track any sort of side effects. And so that is actually part of the paperwork that you provide patients when you give the vaccine. They can go to that website there and read more about it, but it's essentially a QR code that the patient can scan with their phone, and it takes them to a website where they can register, and they'll get a text every day for a week or so, and then every week for a little while, just to see how they're feeling, and then to see if they have any side effects, if they have had a positive pregnancy test, things like that. And then all patients are considered fully vaccinated 2 weeks after either their second dose of Pfizer or Moderna or their first dose of the Jansen or Johnson & Johnson. These are my resources. These are great resources from the FDA and the CDC. It's everything that you need to know: storage, handling, administration, everything you need to know is right here. There's fact sheets. They're well laid out. I would recommend printing it out as a resource if you're going to be using any of these vaccines. Thank you very much.
Hello, everyone. Thank you, Dr. Jones. I'm going to try to avoid duplicating some of the information that Dr. Jones provided to us. But my title is "You Miss 100% of the Shots You Don't Take," Wayne Gretzky and Michael Scott famous quotation. We're going to review contraindications, adverse reactions, and other considerations with the COVID-19 vaccines. I'll let you look over the objectives yourself, basically just become familiar with the components that I had discussed. And as Dr. Jones had mentioned, there are 3 currently approved authorized COVID-19 vaccines: 2 mRNA, one that is the non-replicating vector, which is the Jansen. And I will not reiterate too much of that information. We can go on to the next slide, please. Okay, so contraindications. I know that Dr. Jones also mentioned a little bit to this. So if you've had a severe allergic reaction, if you're administering the mRNA vaccines, if the patient has had a severe allergic reaction to the first dose, then they should not receive the second dose of the mRNA vaccines. So they mentioned any immediate allergic reaction as being a possible contraindication. So hives, angioedema, shortness of breath, those sort of things are what they're considering contraindications. And if there's any diagnosed allergy to any component that is a part of any vaccine or any part of the vaccine that you're providing. So we had talked about polyethylene glycol, PEG, that's found in the mRNA vaccines, and then polysorbate, a related molecule that is found in the Jansen vaccine. Now, interestingly enough, according to the World Health Organization, the cross-reactivity of those two agents, since they are related, is not well documented. There's only 2 case reports out there. There is the theoretical concern since they are a related molecule. Generally, patients tolerate the smaller chain molecules. So polysorbate is somewhat smaller than the PEGs. PEG is found in various different items within the within different household items. So those generally are low small chain PEGs, and most patients tolerate those. There is a very small quantity of PEG within these vaccines, but just something to keep in mind. Generally, patients that are allergic to PEG do tolerate polysorbate quite well. So previously, polysorbate allergies was an allergy to polysorbate was a contraindication to Pfizer and Moderna, but no longer, it's just a precaution. And if there is an allergy, it's recommended to refer to an allergist or immunologist and potentially consider an alternative vaccine. So what are the precautions different from the contraindications? So an immediate allergic reaction to any injectable medicine or vaccine is considered a precaution to these vaccines. And part of the reason why is that, according again to the World Health Organization, about 70% of all injections contain polysorbate 80. So while that's not necessarily always the case, or the possibility of leading to an allergic reaction, generally the excipients are the most common cause to allergic reactions. So most common cause for allergic reactions. So there could be a theoretical cross-reactivity to that. If there is any severe allergic reaction, a 30-minute observation period should be necessary. And if an mRNA vaccine series is not completed due to a severe allergy, you may consider the Janssen vaccine 28 days later. Again, these patients should probably be in a location with adequate resources for anaphylaxis and possibly have some allergist input behind this as well. Now, they consider other allergies to medications or other substances as no precautions. However, if a patient does have a history of anaphylaxis, the CDC does recommend 30 minutes observation after the vaccine. Some patients dislike this, but just something to note. You can observe all others for 15 minutes, but if there is some sort of concern that you have, you could always lengthen the time. And another important note to make is that they do not recommend prophylaxis with antihistamines if a patient does have a higher risk or perceived risk of having an allergic reaction. And that's because giving an antihistamine prior to injection, if the patient does have anaphylaxis, they may have some of the cutaneous symptoms masked by the antihistamine. So you may not be able to recognize the signs and symptoms of anaphylaxis right away if you're giving these antihistamines beforehand. Now, looking at the anaphylaxis rates from December to January 18th, there was a publication that looked at these. The majority onset within 30 minutes. Most patients also have a history of allergic reactions, although a significant minority do have a history of anaphylaxis to other agents. You can see that generally the first dose is where you see this anaphylactic reaction. However, you can also see that some patients are able to tolerate the first dose and then have anaphylaxis to the second dose. In general, we would consider a vaccine, according to the World Health Organization, of having an anaphylaxis rate under 1 per million doses. These do have a little bit higher of a anaphylaxis rate per this VAERS data. But something to keep in mind is you can't really compare those directly. These aren't exactly studies comparing head to head, but there is a possible higher anaphylaxis rate with these agents, and slightly higher with Pfizer. Interestingly, and whether this is a consideration that we should have, is that about 90 to 100% of cases that have been reported from various sources report that female patients are the most common to experience anaphylaxis. And of course, even despite looking at these, notably the rates of anaphylaxis per million doses is still quite low, and the benefits of COVID-19 vaccines still greatly outweigh the risks. Now, moving on to more generalized adverse reactions, most patients will have either local adverse reactions or systemic. Local generally is pain, erythema, and swelling at the injection site. Generally, you will see that the mRNA vaccines have a little bit higher of an incidence of this, although again, these are two different studies. And Jansen, they have just the one vaccine currently, one dose. They are studying the second dose as a possible add-on to this. So perhaps we will see a little bit higher of this. Again, we can't really make conclusions based off of adverse reactions since we're not comparing them head to head, but just something to note. There is also the mRNA patients mostly will have some systemic symptoms, so somewhere between 55 to 83%. But the 55% comes from the first dose of Moderna. Whether that is seen in practice or not is questionable, but generally they do get to about the 70 to 80% mark following the second dose, and Jansen stays approximately at the 50%. Prior COVID-19 diagnosis will increase the risk of these systemic effects after the first dose of an mRNA vaccine. Note that adverse events are not necessarily a contraindication to the second dose, and some of these swelling effects can be quite significant. Younger patients tend to have more severe reactions than older patients, and you generally can manage these with antipyretic or analgesic medications. But do not medicate prophylactically, because that can actually, there is a concern that the efficacy of these vaccines may decrease when medicating prophylactically with either acetaminophen or NSAIDs. So something to just mention to your patients. And we already went a little bit to about reporting vaccine adverse events. These are the adverse events that you must report as a vaccinator. Those four. There is a VSafe app, as we had talked about before. Currently, and I didn't mention any severe adverse reactions other than anaphylaxis or allergic reactions because they're quite rare. In the documentation submitted to the FDA for review, there was about 3 cases each per vaccine. Notably, there was a little bit higher of a Bell's palsy rate in the vaccinated mRNA groups, although they were pretty consistent with what the general population has, and there's been no safety signals. And then also with the Janssen vaccine, there is a possible increased incidence of thromboembolic events. There was 15 versus 10 in the documentation, so they're going to continue investigating that. There hasn't been any announcement in terms of whether there are safety signals related to that, but I'm sure that we have heard a little bit about the AstraZeneca vaccine that is being administered outside of the US. And next slide, please. So a little bit about special populations. So these are patients that may cause some concern, and we ask a little bit about. There should be no concern in regards to Guillain-Barré, Bell's palsy, or pregnant or lactating patients. There has been no safety events in regards to that. Now, in terms of Moderna, there was some concerns with dermal filler inflammation and swelling in the area where the dermal fillers were placed. That is possible with all vaccines and other infections. So the likelihood is that we just saw it with that, unclear reasoning, but any of them could have that. And I want to move on to the next slide just to go a little bit more into our immunocompromised patient population. So there may be a concern that the response to the vaccine is suboptimal. There was a recent study out of Johns Hopkins that found that only about a fifth of transplant patients were found to be seroconverted after receiving their vaccination. And that's compared with 100% for immunocompetent patients. So these are the definitions of patients that would be considered immunocompromised per these different organizations. I'll let you read these over yourself, but I would probably recommend that patients who receive the vaccine and have one of these conditions, I would hesitate to tell them to follow the less strict guidance in terms of quarantining themselves and staying away from others. I would try to keep similar COVID-19 guidance for preventing infections in this patient population that receives vaccines. Other special patient populations that I'd like to talk a little bit about are those that get a COVID-19 infection after the first dose of an mRNA. They may receive the second dose after resolution of their symptoms and discontinuation of their isolation. There was a concern about underrepresented racial or ethnic populations. The subgroup analyses were not powered to find differences in these groups. However, they were very similar to the main group as well. Patients with bleeding disorders may have additional bleeding after the injection. Geriatric patient populations should be vaccinated as all other populations. And adolescents should, of 16 years of age or older should receive the Pfizer vaccine. So other things to consider, other vaccines should not be administered within 14 days if possible. Before or after COVID vaccination. Now you may administer in that time if benefit outweighs the risk, for instance, like a tetanus for a wound. And then medications, the only concern would be related to monoclonal antibodies deferring past the 90 days, but no minimum interval for any other medications. And just a little bit, I do have a little bit more on the other slides, but we can just go over this basically. So not all patients will have antibody tests affected since we're targeting the spike proteins. So if you get a nucleocapsid IgM or IgG, you won't see this. Viral tests are not affected. And then tuberculosis tests should be deferred at least 4 weeks after COVID-19 vaccine or performed at the same time of COVID-19 vaccine. If you get a negative after the COVID-19 vaccine, then it could be a false negative, and they recommend repeating after four weeks to confirm that. And this is just additional information in terms of what to do if there is an error or a deviation from general protocol. We can take more questions at the end, but you can read these yourself. And then next slide, please. And just a little bit, you can see that there's some recommendations in regards to grace periods and dilutions. But if there's any questions, this should be recorded and you should be able to see it. Thank you.
All right. Excellent. There I am. Thank you, Dr. Shilka. So I am Ann Philbrick, and I will be doing the presentation entitled "We All Do Better When We All Do Better," which is a quote attributed to Paul Wellstone, who was a senator from Minnesota. Our objectives are listed here. So we're going to review some data regarding disease progression and then vaccine uptake in various socioeconomic patient groups, and then identify strategies for engaging high risk but less engaged patients with the vaccination process, and review one organization's effort to target and engage this population. So we'll just jump right into some of the data around COVID deaths. So who is actually getting the disease? And this information comes from, the percentage of deaths comes from the CDC MMWR, and then the US population comes from 2017, I believe, interim census data. And so if you just compare things across the board, you notice a couple of things. I will, however, point out that this is a little bit of an apples and oranges data set, because on the left side, the percent of deaths, they are contributing or associating Hispanic with a race, whereas percentage of the US population is associating it with an ethnicity. So you'll see that the percent of the US population equals above 100%, and that's because of the ethnicity of Hispanic people. But one of the things that you see, let's go back, please, on this chart is that in general, we're seeing that whites are having less deaths associated with COVID, whereas some of our other patient populations, including Black or African Americans and then Hispanics, are having increased rates of death. Okay, next slide now. And then this also comes to us from the MMWR, and this looks at excess deaths by race and ethnicity. So this is essentially deaths that were not caused by COVID, but probably were attributed to COVID. So this is deaths like a heart attack that may not have happened because in years past, people would actually go to the hospital, whereas, you know, in early April, people were afraid to go seek out medical help during that time for fear of getting COVID. So you can see by this chart, the age groups that are much more likely to have those excess deaths during that kind of January to September period were the Hispanic age group, the Asian non-Hispanic, and then the Black non-Hispanic. Whereas the white Hispanic, non-Hispanic, and then the American Indian, Alaskan Native, they kind of remain steady. So you see an increase in excess deaths in some of our BIPOC populations. Next slide. And then I wanted to switch gears to just total vaccines given. So this comes to us from the CDC just a couple days ago. And you can see that 31.4% of the total population has gotten at least one dose of the vaccine, and about 18% of the population is considered fully vaccinated. That differs by age, and then mostly by age. If you go to the next slide, there you go, there might be an animation there. If you go to the next slide, this is looking at vaccinations by race. And unfortunately, this is another one that's very hard to look at head to head, because the data on the left comes from the CDC for vaccination by race. And again, they're looking at Hispanic persons as race and not ethnicity, whereas the data on the right side of the screen is that population data from the census, which is looking at Hispanic as an ethnicity. But you can see, as far as vaccination uptake goes, a good portion of the vaccines right now are in the white non-Hispanic group, which is not, you know, above the percentage of the population. But you see that basically every other racial group is lagging behind in population. So you see Hispanics make up 18.4% of the population. They've only uptaken about 7.7% of the vaccine out there. Black non-Hispanics are 7.7% of the vaccine, and they account for about 14% of the US population. So we're really kind of lagging behind in getting some of our BIPOC patients vaccinated. And then this is Minnesota data, which is where I hail from now. And I just really liked how they laid it out because I didn't have to like do that funny math to try to show you what's going on here. So this is all vaccines in Minnesota, and this is the most up-to-date information. And you see that the light blue kind of tealish line is the percentage of that population vaccinated, and then the darker blue is Minnesota population. And again, specifically with Minnesota, and this has been kind of throughout the United States, we're seeing that the white population is kind of overtaking the vaccine number of vaccines out there. And we actually have quite a few white patients vaccinated as opposed to some of our BIPOC communities. Next slide. So the question is, why is this? And one survey tried to address this and tried to see if there was a difference between medical personnel and then general population and their attitudes or likeliness of the vaccine uptake. And so this was a cohort population where they surveyed 2 cohorts of patients in the San Francisco Bay Area of California. The 2 cohorts were, one was a medical employee cohort, and then the second was a general population cohort. Sorry, I cannot say that word right now. And it was undertaken between November 27th and January 15th. So this was about the time that we, saw some of the EUAs approved and saw some of the vaccines starting to roll out. So very timely as far as timeliness. I saw some other surveys that were out there that looked at, ideas of vaccine uptake that were surveyed out back in April, May of 2020. And so the thing I liked about this is that this was kind of real time, like, are you going to get the vaccine? And so they surveyed patients a number of different questions, but they looked at likeliness of vaccine uptake by how patients responded to the 2 questions. How likely are you to get an approved COVID vaccine? And then how early would you ideally like to receive the COVID vaccine? And the graph on the right side of the screen shows the results by race or ethnicity. And we see that overall, the medical center cohort was a little bit more likely just overall to get the vaccine than the general population. But then when you look at different races and how they viewed that question, we saw a dramatic dip between the white population and then other races or ethnicities. And so why is this? And I really, this is a 15-minute presentation. I'm going through it rather quickly, and I don't want to oversimplify it, but there are so many reasons out there for vaccine hesitancy. And the thing that I want to talk about is this idea of vaccine hesitancy. I think anti-vaxxers certainly get a lot of publicity out there, but there are a good portion of people that are just hesitant. And that doesn't mean that they're completely against vaccines, but it has to do with a number of reasons and a number of pieces of information that they're receiving and not knowing which piece of information to believe and trust and that kind of thing. Historically, there is a large mistrust of the government and public health in everyone, but particularly BIPOC patients. There's also a general lack of trust in vaccines, and that comes from a number of different reasons. Vaccines, not being that efficacious in some instances, perceived lack of benefit from vaccines, that kind of thing. And then I think the one that is particularly most important with the COVID vaccines is this concern about vaccine side effects and long-term health effects. And this one really does stem from, knowing that the vaccine came to market really quick, and that concern that maybe it was too quick. Maybe we don't know all of the information out there about it. So next slide. I just wanted to give a couple of blurbs about what we're doing. So I am part of MHealth Fairview, which is a collaborative between Fairview Fairview University Medical Center, and then the University of Minnesota. So it's called MHealth Fairview. And we have two different areas. There's one called the mini clinics, and then we have some underserved patient events. So the next slide will outline the mini clinics, which stands for the Minnesota Immunization Networking Initiative. And it essentially started about 14 years ago, and it was designed to get influenza vaccine into the community. And it was adapted this past year for COVID-19 vaccines. And so really what the mini clinics are designed to do are to partner with faith-based and community institutions to get vaccines into arms. And so this is an example of one that I was able to attend a few weeks ago. That is me on the left side of the screen in the blue scrub that I kind of feel like I'm separated from everybody else. But this was done at Progressive Baptist, which is a community church in St. Paul, Minnesota. And the mini clinic worked with them to get this organized. And so the patients were all either community patients, so lived in the surrounding area of the church, or actual members of the church. And they worked with the pastor and the church leaders in order to get this vaccine clinic up and running. And one of the things that I think is just amazing is that early on in the day, the pastor and the pastor's wife both came in and got their shots and said hi to everybody. And those are the kind of things that really go far in some of these communities, is to show someone that they admire, somebody that is a leader in their community, getting the vaccine and knowing that that person trusts in the vaccine enough. So MHealth Fairview has been doing probably about 4 to 5 mini clinics per week. The other events that we have been doing is these underserved patient events. And these are clinic-based initiatives that have been focused in 6 underserved low-income areas in the Minneapolis-St. Paul area. These are entirely locally supported. So basically, MHealth Fairview gives us a vaccine and we make it happen. And they are specifically for local patients only. What we found early on with some of the populations that were opening up to vaccine was that patients really could only get those vaccine appointments if they had MyChart and if they had a computer, and our patients just don't have that, and they didn't have that access. So we kind of clamored to get these local events. And we have been hosting them since about the 3rd or 4th week of February. Every weekend we have one somewhere in the community. And they've really been great. I do have to say that it's been locally supported is an understatement. I think the biggest thing we've seen is that it really does take outreach from our medical care staff and our physicians, because our patients want to know that this is a vaccine that their doctor, their physician wants them to get. So next slide. So what you can do. So the first thing is to try to build trust. And I know that this isn't something we're going to do overnight, but what you can do is try to engage those people in the community that your patients already trust. So different community groups, faith leaders, and so on and so forth. Being able to have our clinic or have a vaccine clinic at our actual clinic and not making our patients go elsewhere has been very helpful, because they trust our clinic, but they don't necessarily trust, whoever is doing it down at the convention center, that kind of thing. Another thing that helps is to ensure plenty of communication, particularly information in multiple languages that fit the patient population you need. So information that your patients can read and can think about and look at on their own. Increase convenience, so go to the people. So this is our local events and our mini clinics, is to take these vaccine clinics and go to where the people are, and not making them go to a place that they're not familiar with, they've never been to, they don't know how it's going to go. And then finally, a tool I like to use is making the case, which stands for corroborate, about me, science, and explain. And so this is a good tool that, a pharmacist, anyone can use to try to pass on some education to patients that is in a consistent positive message. And so basically it starts with corroborating. So turning around and saying, you know, agreeing with the patient or you know, stating that you're concerned as well, or you could understand why they could be concerned. About me is talking about what you've done to do the research on whatever concern they have. Science is what you found, and then explain is a final recommendation. So if I use this as an example, the patient that might say, the vaccine was made too fast, and I'm worried that they cut corners. So I might say something like, you know, I was kind of concerned about that too. It really was, it really came to market pretty fast. I was so concerned that I decided to look into the literature a little bit about it myself. And this is what I found. I found that a lot of people worked together to make sure that this vaccine came to market. And a lot of things that were cut out actually had to do with the waiting time between studies. And that's what really made it come to market quickly. Also, the CDC would not have allowed, or the FDA would not have allowed this vaccines or these vaccines to come to market if they were unsafe. So if it were me, I would get the vaccine. And in fact, it was me and I did get the vaccine. So, you know, you can kind of experiment with that on your own. And I think that might be it. All right. And I think now we're going to open this up for a panel discussion.
Yes, this is Stephanie Nigro. Thank you so much, Drs. Jones, Shilka, and Philbrick, for sharing your expertise with us this afternoon. It does look like there's about 2 or 3 questions that we received, so I'm just going to read them, and whoever wants to answer, please do. The first question was, how are patients learning about the VSafe program at your immunization sites?
So I can speak to you about that. So every patient who gets a vaccine at our site, we give them 2 documents from the CDC that I will post in the chat. One is what to expect. Another is information about the VSafe that has the QR code on it. And then they also get a copy of the EUA of whatever vaccine they're getting. So every patient, when they check in, they get those pieces of paper, their vaccine card, and then their little sticker.
Wonderful. The next question is related to corticosteroids. So what is the recommendation for patients who are receiving corticosteroids? Should they receive the vaccine? Should someone wait to receive the vaccine if they're temporarily receiving steroids? If so, how long after stopping steroids should someone wait to get the vaccine?
So I can answer this question. I don't think that there's one single case that will fit everyone. Generally, they consider at least 20 milligrams equivalent a day of prednisone, or 2 milligrams per kilogram per day of prednisone equivalent to be a dose that is considered immunosuppressive. And I would think that they would need to receive it for at least 2 weeks. One of the pain societies recommends holding off on vaccinating by 2 weeks if possible, if someone is receiving, let's say, like an intra-articular steroid injection. But I think that you would probably just have to make it on a case-by-case basis, because depending on the availability of appointments and whether the patient was taking a substantial dose during that time period. If they're only able to receive a dose of the COVID vaccine during a certain time and they've recently received steroids, I wouldn't necessarily consider that a contraindication to receiving it. Now, if someone has been receiving that immunosuppressive dose for 14 days, I think that gets a little bit tougher. I don't know that there's been studies showing, or I'm not aware of any studies showing what the optimal timing and what with that would be. So that I couldn't answer, but they do have recommendations for chemotherapy from the Hematology Society, where you can potentially defer vaccination. Well, they recommend either vaccination 2 to 4 weeks before the immunosuppressive therapy or several months after, but the CDC doesn't have that as a specific recommendation. And while the antibody response is somewhat decreased in the patients that were in that one study, I think drawing conclusions and making recommendations off of that right now may not be the greatest, but yeah, case by case basis.
Great. Thank you. The next question is there any data or information that talks about vaccines and an association with sterility?
I can speak a little bit to this, not a lot. From what I understand, they're actually the patients, the people who enrolled in the clinical trials for these vaccines were told not to try to get pregnant because we didn't know, and they were told to use birth control. And there were a number of people in the trial who did get pregnant and did deliver healthy babies throughout the course of that. Right now, there is no data from the CDC that there's any risk of problems with fertility. Obviously, we don't know everything, but based on what we know so far, there's not an issue with that.
And I was going to jump on just to add something. I actually did read this. This was from the ID Society. There was misinformation on the internet that was going around that once you get the COVID-19 vaccine, that you develop some sort of antibody to a protein related to fertility. I forget what it is off the top of my head right now, but in terms of the FDA briefing documents, there was a similar amount of pregnancies that occurred in both the placebo and the vaccine group. So.
Thank you. There's 2 more questions. Hopefully we have time for them. But the next question is, can patients with Guillain-Barré syndrome receive any of these vaccines?
Yes, that's not considered a contraindication. There's not been any safety evidence to suggest that it would not be safe in that patient population.
Great. And then the last question that we have here is, what should we tell patients who are wondering if they can still transmit COVID after getting the vaccine?
Yeah, so we don't know for sure. There is no guarantee that a vaccinated person cannot transmit. They're currently doing more studies on that. So that's why all of us who are fully vaccinated are still wearing our masks. I think that it's greatly decreased, I believe, is what they're learning so far, but we cannot guarantee that you don't have an asymptomatic infection even after having gotten the disease, because it is not 100% effective. So I think until we get closer to herd immunity and learn more, have more studies, everything's constantly being studied once we know more. But until then, we are still protecting others by wearing our masks.
Great. It looks like that's all the questions that we have in the chat or Q&A. So it looks like we're right on time. I don't know, Takova, if I'm turning it back over to you.
Absolutely. Thank you so much, Stephanie, for facilitating that Q&A. Thank you so much to our panelists for the awesome information that you provided today. I know we've all been hearing so much about COVID vaccines lately, and we've been overwhelmed with so much information, but it's nice to hear it and to hear it from different perspectives and just to get a different vantage point on what we need to be doing moving forward, especially as more states are opening this up to full population vaccination efforts. So thank you all so much for your time. And lastly, thank you to all who were able to participate today. We understand and appreciate that you have been occupying a lot of virtual spaces lately, and you decided to spend an hour with us learning a little bit more about the vaccines. So thank you so much, and we'll work to get this posted for those who want to review it again or for those who were unable to view it. So thank you so much, and have an awesome rest of your day.